Hello, my name is Benjamin and welcome to Med One Pager. So today we're going to talk about liver cirrhosis. And when we talk about cirrhosis, this is going to be the progressive fibrosis and formation of nodules in the liver. So the liver has a complex architecture. Normally blood, most of the blood going to the liver is going to come from the digestive system, and most of this blood is going to pour into the hepatic portal vein, which enters into the liver, and through complex venous networks, blood saturates through the liver. It passes through there, enters into the sinusoids of your liver, which are just basically spaces in the liver. And as blood squeezes through the sinusoids, toxins are being removed, metabolized, and excreted. So what happens that when there is cirrhosis and there is fibrosis, the architecture inside here is going to become distorted. And remember, the blood is always going to come and try to pass through the liver. So when you destroy this architecture, you cover the sinusoids, they are no longer patterned, the pressure is going to build. And the pressure that is going to build is going to cause one of the very, very characteristic features of liver cirrhosis, which is portal hypertension. So in someone with liver cirrhosis, which is actually a chronic liver disease, is going to have features of portal hypertension, which may not actually be present in most people with an acute liver disease. And I'll make a video about acute liver disease and I'll try to pull out the differences then. So when we concentrate here, the causes of cirrhosis are going to be quite a number, but most commonly in low economic settings, it's going to be alcohol, it's going to be a viral hepatitis, and maybe an infection, any other infection, yeah. But other causes that are common include the autoimmune diseases like autoimmune hepatitis, the primary biliary cholangitis, and primary sclerosing cholangitis. Look at chronic alcohol. Alcohol is going to cause cirrhosis, which has been given as patient name, talked about as alcoholic cirrhosis. But basically what happens is that when someone begins taking alcohol, the alcohol is going to alter the liver architecture first by causing a deposition of fat, which is known as hepatosteatosis. Yes, hepatosteatosis, which is the basically deposition of fat into the liver. Then after that, this part is going to cause an inflammation, and the inflammation is going to cause a steatohepatitis. So the stage 1 of alcoholic liver cirrhosis or alcoholic liver disease is going to be hepatosteatosis, which is the development of fat in the liver, and then it is going to be followed by steatohepatitis, which is the hepatitis or the inflammation of the liver, which is having that fat. So what you could call fatty liver. And after that, if someone becomes a teetotaler, they stop drinking, it is possible to reverse and go back to having a normal liver. But if they don't, they're going to progress to now the alcoholic cirrhosis, which unfortunately is going to be permanent. So that is to do with the alcoholic liver disease. And when you look at the non-alcoholic fatty liver, this is going to be common in people with like diabetes or metabolic syndrome, obese individuals. And we have other metabolic and genetic factors that are actually not uncommon as you may think. We have things like hemochromatosis, when we have a lot of deposition of iron in the body or iron overload in the body due to a mutation of a certain gene that helps with the expression of that iron. We have Wilson's disease. We have alpha-1 antitrypsin deficiency. So Wilson's disease is basically an accumulation of copper in the body. And we have some infections like schistosomiasis. We have syphilis. We have toxins like methotrexate, aflatoxins. And these ones are very, very common also in low-income countries where food storage is not very good. And we have chronic biliary obstructions. So problems with the gallbladder could also extend and cause a cirrhosis up there. as well as vascular disorders like bad carry. Now, bad carry is basically a formation of clot in the hepatic vein, and this is a vein that is removing blood from the liver and taking it back towards the heart. So if somehow we have a clot there, it's going to cause a back pressure, and whenever the liver is congested, it is going to that's going to cause a lot of problems. It's going to not be able to carry out its function very well, and that is eventually going to lead to cirrhosis, or that chronic inflammation that will lead to a cirrhosis. And as now you can tell from that, the congestion, that is how also the chronic right heart failure is going to cause cirrhosis, and that one is called cardiac cirrhosis. And we have veno-occlusive diseases. This is just a formation of thrombi, or someone maybe is prone to getting thrombi, maybe they have a polycythemia, maybe they have a protein C and S deficiency, any of that thing. It's going to cause formation of clots in the hepatic vein, and this eventually is going to cause to a backlog of blood in, or a pooling of blood into the liver, and this is going to eventually lead to a cirrhosis. So when you try and look at the clinical features are going to come from the two things that I've talked about. One is going to be features of portal hypertension, and two, it's going to be features of impaired function. So most of what I have here is going to come from that, and once you put that in your mind that I'm losing function of the liver, or I'm having a high pressure in the portal system, you have all the clinical features. So generally there may be some fatigue, there may be weight loss, anorexia, and this is very non-specific, and it's just basically because you're having a chronic illness in the blood. Fever, which may be low grade, because of inflammation and infection. Then we go to the skin. Jaundice is very common because, of course, you can tell the liver is important in bilirubin metabolism, and once that is gone, the levels of bilirubin will rise, and the yellowish tinge on the skin, which is jaundice. Then we have the spiderangiomas, we have the palmarythema. Now, the liver is important in regulating the levels of estrogen in the blood. It actually helps to clear estrogen from the blood. It metabolizes the estrogen. So when the liver is cirrhosed and the function is impaired, estrogen is going to increase, and when estrogen increases, it is going to cause that vasodilation. And the vasodilation is going to appear as spiderangiomas, maybe on the chest, on the arms. And then we have the palmarythema, which is also from the excess vasodilation. So this can actually be an early feature in someone with cirrhosis. You look at their palms and they are very red. That is the palmarythema. They can have easy bruising and papilla because of coagulopathy and thrombocytopenia. And coagulopathy is going to come from, one, the liver is not producing the clotting factors very well. These are not going to be produced by the liver, and it's going to be a problem. Then the thrombocytopenia. Now, when we have a backlog of blood in there, or when we have an increased pressure in the hepatic system, blood from the spleen normally comes and enters into the liver, it enters into the hepatic portal vein. So when the pressure is high in the portal vein, part of the blood that is going to the spleen is going to cause a back pressure within the spleen, and the spleen is going to enlarge. And when the spleen enlarges in size, you're going to have a hypersplenism. And when the spleen is highly active, it's going to keep removing some of these cells of the blood, and one of those is going to be the platelets. So we shall have a thrombocytopenia. We would also have leukopenia and an anemia also, just arising from the hypersplenism. Then we have pruritus from cholestasis. So if your problem is coming from the gallbladder, and maybe we have a stone that is constructing the duct, and then we have everything happening up, the pruritus will come in, because the bile salts when they enter into the blood saturation and they deposited into the skin, they cause that kind of itching. We shall have the lymphomastia because of the increased estrogen. The testicles will atrophy, and then we have menstrual irregularities. Most cases, the periods are going to cease because we know estrogen prevents the shedding of that endometrium. So when you have a high estrogen, when it's supposed to be low actually to allow the endometrium to shed, that is going to cause a problem. Then we have the When we go to the abdomen, we may see hepatomegaly. The liver may be big in early stages, but as the fibrosis goes on and on, it's going to decrease inside. You can have a splenomegaly, which I explained is due to the pressure increasing in the portal system where the splenic vein is supposed to pour a bit blood. So when we go to the ascites, these are going to be basically also because of two mechanisms. One is the albumin is low because the liver is not producing the albumin, and the other is going to be due to the portal hypertension. Then we shall have the caput medusa, which are basically the veins that radiate around the umbilicus, and they'll try to look like the known snakes on the head of Medusa. Yes, so that is where the name comes from, caput medusa. And these are basically collateral veins that are forming because the system realizes all my blood that is coming from the GIT is entering a blocked system. So it tries to create an alternate system that will skip the blockage. So this try to take the blood from the GI directly into the system, into the systemic circulation to bypass the liver. And this is one of those collateral veins formed on the abdomen called this caput medusa. Then we have the Asterixis or the flapping tremor. This is due to hepatic encephalopathy, and I will cover hepatic encephalopathy in detail in the video for acute liver failure, because one of the hallmarks of acute liver failure is hepatic encephalopathy. Then we shall have confusion and coma, which is due to ammonia accumulation, because ammonia is produced from the GI by the bacteria there. It is also generated during protein metabolism, so it is not a shock that we shall have ammonia accumulating, and when it crosses the blood-brain barrier, we shall get confusion and coma. Then there are some special associations that we see. Maybe someone comes in with cirrhosis and they have a parotid enlargement, or they have a deep uterine contracture. That is going to be more common in people with alcoholic cirrhosis. If they have a bronze-colored skin and diabetes, we could call it bronze diabetes. That is common in hemochromatosis. When we have the facial rings seen on a slit lamp, that is Wilson's disease. So what we're going to do when we are approaching a patient with cirrhosis is that we are going to screen for the causes, we're going to assess complications, and then we assess the function of our liver. So when we're assessing the screening for causes, we can do the viral serology, we can do metabolic panel, we can do almost anything that tests for those causes that we suspect as we saw them up there. So basically that's what you're going to do. Then you want to assess the complications. You want to do a CBC to check, does my patient have anemia, thrombocytopenia, leukopenia, probably from the agasplenism or from the impaired function of the liver. We want to see, do they have proper renal function? Because one of the complications of liver cirrhosis is hepatorenal syndrome, whereby the cirrhosis of the liver, whereby someone with liver cirrhosis ends up with a renal failure. And this is basically most of the times going to come from the reduction in the effective volume circulating. The intravascular volume has contracted due to from extravasation of the fluids due to the low proteins causing the ascites and everything. So the fluid in the pressure is reduced, and the renal system tries to maintain the pressure by constricting the renal arteries, which in the end ends up reducing on the glomerular filtration, and this in the end ends up giving us a functional renal failure, whereby the structure of the kidney is actually fine, but we are having a decreased glomerular filtration rate, and we are having features of renal failure. But it is due to not actually an intrinsic pathology or problem in the liver. Then we want to assess for the function of the liver. We do the liver function test, that's the ALT, AST, GG. And then we want to do the INR, I want to do the albumin. INR is the international normalized ratio, so we are comparing the bleeding time of our patient to the clotting of our patient with the normalized with the one of normal individuals, and we get what we call the international normalized ratio. We are comparing those. Then we have, so when we're going to the management of alcohol, we're going to begin by aborting the causatives. What is causing this cirrhosis? We try to remove the alcohol, we try to remove the hepatotoxic drugs. We want to treat the underlying cause if it's treatable, if it's a disease, if it's like Wilson's or anything else, we can try to remove that underlying cause, and that would help prevent or will help to delay the continuation of the disease. But as we said, cirrhosis cannot be reversed. So basically, we're just halting the progression of the disease. Then we want to give a nutritional support, and the only curative measure is the liver transplantation. So we have some scores that we use during the manual to maybe classify the patient to see the mortality risk. We have the Child-Pugh score, or then we have the MELD score, which is mostly used when considering transplantation. So when we come to the complications of liver cirrhosis, and this is a very, very big thing when it comes to liver cirrhosis, and most of the time this is what you're going to be managing, or what is going to be bringing your patient into the hospital. And the also is going to be portal hypertension. As you said, portal hypertension is going to come from a distortion of that renal vasculature, and the vasculature within the renal system is going to be distorted, and blood can no longer move, and that is going to cause the pressure in the hepatic portal vein to increase. And basically, that is going to be managed most of the time with a beta blocker, a non-selective beta blocker, like propranolol, onodolol, and these ones are going to reduce the portovenous flow. We can do a TIPS in some cases, which is the transjugular intrahepatic portosystemic shunt, because you can see the pressure in the portal system is high. So if you create a shunt, it would give some relief. It would reduce that pressure, and most of the symptoms that come with having the portal hypertension are going to remit, especially if they are refractory, are going to remit. And the problem with this is that, again, we are escaping the liver and we are taking the blood even faster to the systemic circulation, and most of the time it's going to cause the hepatic encephalopathy now more even easier. Then we have to avoid drugs that may worsen, or the drugs that may worsen or lead to the risk of bleeding. So we have like NSAIDs. If someone has like constipation, remember, as the pressure increases, when the portal system pressure increases, we tend to have two things happening. So on the abdomen, we have the development of the caput pneumotosa. When it comes to the lower GI, we have hemorrhoids forming, and then it comes to upper GI, we have the formation of the esophageal varices. So as the pressure increases, these are going to become engorged, and sometimes they end up bleeding. So it's important that when you're managing your patient, you avoid NSAIDs because of the associated with the risk of bleeding, but also you avoid constipation, because this person, if they are passing very hard stool and they have hemorrhoids, they're going to be bleeding, and that will be a problem. Then we have hepatic encephalopathy, which is basically when ammonia reaches and other neurotoxins, they're supposed to remove the liver, reach the cerebral perfusion. When they reach there, they're going to cause a cerebral edema, and the cerebral edema will cause those neuropsychiatric changes. And most common precipitating factors are going to be like GI bleeding, infection, constipation, dehydration, high protein load, and electrolyte balance. And to manage this, you have to first consider those precipitating factors. And when you try to remove them, you try to remove them, then we can give drugs like lactulose, which helps to decrease the colonic pH. And when the pH is low, the ammonia is going to be converted into the ammonium ion, and this is going to not be able to cross the blood-brain barrier more easily. Then you have its catalytic effect, whereby then you go to rifaximin. So rifaximin is a non-absorbable. It's not good. It's not easily absorbed, so most of it is going to remain in the gut. It's an antibiotic, and it's going to kill this nemeflora that will help treat the ammonia, and this will, in the other end, reduce this. So sometimes we try to do protein restriction in acute episodes, but in long time we want to maintain adequate nutrition, because as you can tell, we do not want our patient to become malnutritioned. Then when we go to hepatorenal syndrome, one of the causes is that we have a splanchnic vasodilation. So the blood vessels of the GI system are going to vasodilate, or the gut are going to vasodilate, and because of the vasodilation, pressure will be a lot of blood is going to pull there, and the pressure within the arteries is going to fall. So the renal artery will try to constrict to reduce try to constrict to maintain the pressure, but this will decrease further the renal perfusion, and this is going to cause the functional renal failure, and I talked about this earlier. So the management is going to prevent to avoid nephrotoxic drugs and overdiuresis, and then we're going to avoid nephrotoxic drugs and overdiuresis. We can give albumin infusion, we can give vasoconstrictors. All this we are trying to maintain the blood pressure, and we can do the tips in some cases, in selected cases. Then we have some spontaneous bacterioperitonesis. This is where we have someone with ascites, and then bacteria from the gut actually translocates into these ascites, and because the ascites have a low immune system, they are low in complement, that immune dysfunction existing is going to allow these bacteria to grind. They'll have this spontaneous bacterioperitonitis. So mainly we're going to manage with the empiric antibiotics as cefotaxime and ceftriaxone. And when you're doing secondary prophylaxis in someone who has had the spontaneous bacterioperitonitis before, we are going to use the fluoroquinolones, which is norfloxacin or ciprofloxacin. Then we have hepatocellular carcinoma. Remember, this liver is undergoing chronic inflammation and regeneration and everything. So at one point, there are genetic mutations that occur because of this continuous regeneration, and we may end up with a malignant transformation. So it's very important that every 6 months at least, we screen these patients for hepatocellular carcinoma using an ultrasound and alpha fetoprotein. And some of the options for treatment, we have the resection, we have liver transplantation with ablation, you have the test, you have the systemic therapy with the sorafenib and lenvatinib. Then we have coagulopathy, and coagulopathy we say is going to come from two mechanisms. One is going to be the hyperplastonism, and the other one is going to come from the decreased synthesis of the protein factors 2, 7, 9, and 10. Then ascites. So when someone has coagulopathy, you can manage by giving fresh frozen plasma if they are actively bleeding, and you can give a platelet transfusion if they are platelets fall below 5,000. When it comes to ascites or ascites, they are going to come from the increased hypertension and low albumin. And because of this, we shall have the activation of the RAS system. And when the RAS is activated, you're going to retain more water and more sodium, and that is basically what is going to cause the ascites. In the management, we are going to do a salt restriction to less than 2 grams per day. We are going to give some diuretics like spironolactone plus furosemide. We can do large volume paracentesis when we give IV albumin, and then we can do tips or the transjugular intrahepatic photosystemic shunt if we have a refractory case. Then lastly, the last complication is variceal bleeding. And this is due to dilated submucosal veins, the rupture, and the high blood pressure. So as I talked about, similarly to this, when we don't have these dilated veins in the esophagus, they can occur as hemorrhoids. So what you want to do is that you want to resuscitate, and you want to give vasoactive drugs like octreotide and calipressine. You want to do endoscopic bad lication with sclerotherapy, and you can give antibiotic prophylaxis with ceftriaxone. So, and that is how you prefer. And if you want to prevent this variceal bleeding, you basically have to reduce the portal pressure, and that in that case we give them non-selective beta blockers. So liver cirrhosis is a very big topic, and I tried to summarize it and its complication in the best way I could possible to fit on one page. But a lot will be discussed in more videos about hepatology, more in acute liver failure. We may expand on some of these things like portal hypertension on their own. Thanks. So if you like this video, if you have any feedback, or if you just really want to support me, I would appreciate if you left a comment, like the video, or share the video with a friend.